Good morning and good afternoon, everyone. Welcome to today's meeting, Expanding and Activating the Front Lines of Care, our third meeting of the Davos Alzheimer's Collaborative Healthcare System Preparedness Learning Laboratory. I'd like to thank everyone for joining us today on behalf of the Davos Alzheimer's Collaborative. We have today over 540 registrants. We have 73 countries represented and 280 organizations reflecting the global interest in the topic of Alzheimer's and how to prepare for its future. My name is George Vredenberg. I'm the founding chairman of the Davos Alzheimer's Collaborative. A word about DAC, as we intimately refer to ourselves. This is a partnership of the Global CEO Initiative on Alzheimer's Disease and the World Economic Forum. It is designed as a whole of society approach to the Alzheimer's pandemic. Much as we've approached infectious diseases through the Global Fund, Gavi and CEPI, the World Economic Forum, and we believe strongly that the Alzheimer's pandemic is a global health crisis of comparable scale and of magnitude. We are advised by key global experts in science, finance, and healthcare. We're forming critical partnerships with international organizations, including the World Health Organization, and national governments, and industry, and patient advocacy groups, and researchers to drive progress to advance the treatment and management of Alzheimer's. The timing of this meeting is very, very important. As we all know, Alzheimer's is a growing pandemic that continues to threaten and devastate families and health systems around the world. 50 million families today being affected, tripled by mid-century, 150 million, as the demographic aging process continues globally. It also costs the globe over $1 trillion in costs annually every year, doubling every 10 years, meaning that in the next 10 years, perhaps $15 trillion in costs to the global economy as a result of this disease. At the same time, we have new evidence from the drug produced by Eisai Corporation of Japan that we actually can modify the course of the disease. For so long, we've been trying to touch this disease, and it's been unreachable to us, and yet the Eisai Corporation and its partner Biogen, Japan and the United States, have brought forth a drug whose late-stage trials demonstrate we can touch this disease, we can modify its course. It is certainly not a cure. It will slow down the course of the disease, meaning that if you have access to this drug in the earliest stages of the disease, you will be able to experience another 2 to 3 years of functional performance and in your activities of daily living. It does, however, stimulate innovation in now other companies which want to produce a more powerful drug, one that's more effective, or in combination more effective. Therefore, the timing of this meeting is important, both because the pandemic is growing and we have some now significant evidence that we can modify the course of the disease. At the same time, we also know that there are some challenges. The means of diagnosing this disease today require a PET scan, which is inaccessible to most parts of the world, and indeed to most parts of the high-resource countries as well because of its cost and its limited accessibility. The paper and pencil tests we use to detect cognitive impairment are now being challenged and updated and revolutionized by the possibility of doing this through digital diagnostics or digital cognitive assessments, which will be much more accessible, much more available to individuals in their homes and to health systems as a mechanism to test whether or not their populations ought to undergo what are perhaps the more exciting, even more exciting diagnostic tests that we now can discern through human blood. So we have a challenge in front of us that's growing, but we have some new evidence that we can modify the course of the and we have new diagnostic techniques which will make the ability to diagnose this disease in consumer or community-based health systems or in private health systems at the primary care level. So we have a time of both threat and promise. Today, we're gathered to change the trajectory of this disease, to galvanize action on this grave and urgent health challenge, and to answer how and why we can act together and how we can learn from each other to make progress individually or together. Field is more dynamic, as I've said, as we've shown both progress on the drugs and the diagnoses. Now is the time to ensure that we have a healthcare system infrastructure and capacity to support these new and emerging innovations to attack this disease. This meeting marks the third meeting of the Davos Alzheimer's Collaborative Healthcare System Preparedness Learning Laboratory, a mechanism by which stakeholders across national public health organizations, policy, research, and industry as well, in high, medium, and low resource settings, can come together to share learnings from the Alzheimer's research initiatives aimed at common operational challenges in delivering new innovations to those at risk for the disease or living with the disease today and their families. Through a series of convenings hosted by the Davos Alzheimer's Collaborative Healthcare System Preparedness Learning Laboratory, our hope is that representatives will be able to engage and learn from other colleagues in other jurisdictions how best to attack this disease at a practical level and assure that innovative treatments or risk reduction interventions can be introduced into clinical practice universally and around the world. As most of the people living with this disease, certainly the way beyond the majority, live in low and middle income countries. So while all of us, in a sense, are new to this game and can learn from each other. So we want to make sure that solutions are sustainable and scalable for all resource levels, drive changes from both bottoms up and top down, coordinate new care models and diagnostic models with existing policy initiatives, tailor for local cultural context, and prioritize innovative approaches to detection and diagnosis. Pleased to be joined by all of you today, representing a highly diverse group of stakeholders, both public and private sectors from all countries or many, many countries of the world. We hope this is an interactive dialogue, a place where we can continue to learn from one another. So I ask that if you have any questions as we go through the day, please put them in the chat and we will be able to respond in real time. I'd now like to introduce our first speaker, Dr. Julio Frank, President of the University of Miami and member of the Davos Alzheimer's Collaborative Board of Directors, who's joining me in a brief fireside chat this morning. Dr. Frank is a noted leader in global public health and a renowned scholar and academic. Prior to joining the University of Miami, he was Dean of the Faculty at the Harvard T.H. Chan School of Public Health and the T.N.G. Angelopoulos Professor of Public Health and International Development. Dr. Frank served as the Minister of Health of Mexico from 2000 to 2006 and pursued an ambitious agenda to reform the nation's health system and introduce a program of comprehensive universal health insurance, expanding access to healthcare for tens of millions of uninsured Mexicans. Dr. Frank, thank you very much for being here with us today.
Thank you, George. I'm delighted.
Today, we're coming together to discuss how to expand and activate the front lines of care to enable early detection and diagnosis of Alzheimer's disease, to permit the introduction either of risk reduction strategies or therapeutic interventions as they become available. From your perspective, given your leadership both in the Mexican government and still as a global public health figure, how do you see the components of delivering healthcare to the population? Traditional health systems, or are there other elements of sort of the front lines of care we should consider?
Well, let me put in context the very impressive figures you were mentioning at the outset. regarding Alzheimer's. This is happening as we are still living what has been called a health revolution that started basically at the beginning of the 20th century and is still ongoing. During this period of time, we have seen larger gains in life expectancy than in all the previously accumulated history of humankind. But it's not just that we've seen dramatic drops in mortality, it's that the entire pattern of diseases characterizing populations has shifted. And this epidemiologic transition has totally modified both the type of diseases that we're dealing and the way we experience those diseases. For most of human history, the experience of disease was as a succession of acute episodes from which either you recover or die. And if you recover, you went on to get sick from the next acute episode. Instead, today, what defines the epidemiologic profile around the world, and this is around the entire world, is the idea of diseases becoming a condition of living, of people spending large periods of their lives in less than optimal health. And the way we talk has changed. We say, I have a cold, but you say, I live with Alzheimer's, or I live with cancer, or with HIV/AIDS. It's become a condition of living, very often stigmatized. And the problem is that this huge, massive shift, which we tend to lose sight of because it happens cumulatively over long periods of time, this massive shift in the type of diseases has not been matched by the type of health systems we have. Part of the health revolution that started in the 20th century was the development of massive health systems. That had not happened historically. But today we have these large health systems which represent the largest sector of the largest economy in the world, the US, and about 10% of the global economy, with huge impact on the way the rest of the economy functions. Just look what happened with the pandemic, if we needed any proof of that. And yet the health systems have not kept up. We still have very much a health systems based on episodic care. It is time now to change the way we structure health systems so that they respond to these characteristics. And I share your optimism. This is a huge challenge. We still are facing around the world what I would call a triple burden of disease. We still have a huge unfinished agenda of the common infections, the maternal deaths, the undernutrition. That's still there in large parts of the globe. At the same time, we have this emerging set of mostly non-communicable chronic conditions like Alzheimer's. And then on top of that, you have the challenge of the health conditions directly deriving from globalization, like pandemics or the health effects of climate change. So setting priorities at the national level is a very complicated affair. But the only way we can do that is if we get our health systems to match this complex reality, and we take advantage of the huge amount of innovation that's going on. You just mentioned some of those. And this is both technological innovation in the biosciences, but it's also technological innovation in many other fields, information and communication disciplines. And it is also innovation, not just in the technologies, but in the way we structure, finance, and manage the health systems in which those technologies necessarily have to be applied. So it's a time of great challenge and also of great promise, as you said at the beginning, and that has huge implications, of course, for the future of Alzheimer's care.
You describe a situation we find ourselves in today where we are treating people after they become sick. Let me ask you, is it important for us to begin to think about how to assess diseases before they manifest themselves into sickness and to try and prevent them? There's a shift from treatment to prevention.
Absolutely. We need part of that updating of our health systems is to move from a mindset based on repairing to a mindset based on anticipating problems. In fact, very often the key of the cornerstone of any high-performing health system is primary care. But we've tended to identify primary care with primitive care, with care that's of low technological content and dealing with the frequent stuff, and basically as in a gatekeeping function. You go to primary care to then access the really sophisticated, complex care. We need to change that. Primary, in my mind, means addressing the first causes. The primacy there is that you go to the root causes. And that means adopting an anticipatory perspective. And we now have the technologies to do that because, from the genomic revolution that allows us to personalize risk and really practice personalized prevention, to the empowerment of people. Let's not forget that health systems are not just the institutions and specialists that work in those. People are part of the health system because people are co-producers of their own health. Today, through advances in sensors and much more access to information, we can empower people to also be active participants as co-producers of their own health. That is the promise of primary care. Couple that with advances in artificial intelligence and machine learning, the enormous progress we had that was accelerated by the pandemic in remote formats for care, the rise of virtual digital assistants that can actually help steer people and mobilize that empowerment. And you have the ingredients for moving towards anticipatory health systems as the cornerstone that anticipate. And in Alzheimer's, this is critical because a lot of the technologies you were mentioning, especially pharmaceutical, do work when there's early detection. Early detection is absolutely critical when you have a progressive chronic disease to stop that progression, or at least to slow it down, eventually to stop that progression. So that I think is one of the key elements in this rethinking of primary care and of health systems in general, adopting an anticipatory mindset.
Well, fascinating observations, but you also describing a shift potentially from sort of a system where you have specialists for particular diseases to a system where you have a primary care lead who crosses all diseases based upon the individual in front of him or her. I've heard you speak about shifting from a vertical system to a horizontal system and other ways of thinking about how we ought to be approaching these chronic diseases, which include Alzheimer's, but also include diabetes, include hypertension, include a variety of other conditions, rather than treating each one and having a specialist for each one, having a primary care system which can look at all of that human being and decide what is the right appropriate detection and then intervention strategy for that individual.
Yes, absolutely. Because we have this triple burden of disease that I was describing, we still have an unfinished agenda. I mean, let's not forget that there's still way too many maternal deaths. And even though, since 1990, under 5 mortality has dropped by 60%, and an incredible achievement. Again, we lose sight of these things, but we still have way too many children succumbing to malaria and other diseases, infectious diseases that we ought to have controlled by now. And then, we do have pandemics. We're still in a pandemic of infectious diseases, COVID-19, and then we have this tsunami of chronic progressive diseases like Alzheimer's. So setting priority is a complex issue within a country. I served as Minister of Health for 6 years in an upper middle income country. And that was probably the single most difficult policy decision. What do you prioritize in the middle of all of this? I think, and that has led to a big divide in the health policy community. There's a group that basically espouses what are called vertical approaches, defining a limited set of priorities and then focusing on those. Those vertical approaches have provided a lot of benefit. The eradication of smallpox is the emblematic vertical approach. A focus on one disease, focusing on vaccination to eradicate. It's the only disease we've eradicated. We're close to eradicating polio, another vertical program. The problem with that is that it focuses priorities, but it fails to recognize that health systems also take care of many other conditions, and people don't come to the health system with a diagnosis. The first thing you need to do is identify the problem. So that has led the other camp, which is the so-called horizontal approaches, which say, let's just structure health systems in general, and then they will deal with the mix of cases that present either to a clinic or that are present in a community. My colleague Jaime Sepúlveda currently at the University of California in San Francisco, came up with the idea of extend this geometric analogy and saying, let's develop a diagonal strategy. A diagonal strategy means you do have clear priorities based on the burden of disease and other criteria, but you use your focus on those priorities to introduce generic changes that will strengthen the health system and make the health system better prepared for dealing with other priorities. Because don't forget, in health, we're always victims of our success. As we vanquish certain health problems, others arise because, we are all human. We all are going to die of something. The health revolution of the 20th century is an example of being victims of our own success. We managed to reduce mortality from common infections, killing lots of children, and therefore we extended life expectancy and lifespans. As we do that, people live long enough to develop conditions like Alzheimer's and other chronic conditions. So the diagonal approach does focus on priorities, and there's no question that Alzheimer's has to be way at the top of that, and uses that focus to introduce generic elements of strengthening the health system so that it's better prepared to deal with everything else that health systems deal with.
We have a comment from chat from Tanzania that basically says that health systems are not used to treating diseases of the brain. So frequently those with dementia treated as having some psychosis that requires incarceration or other institutionalization, as opposed to treating them as a disease, treated as a natural cause of aging, in which people tend to get psychoses in age. So you're absolutely right. That requires some vertical understanding and some horizontality in terms of how to deal with the risk factors that bear upon and create increased risk of late life dementia. ADI has done some polls that says over 60% of both clinicians and of the population believe that Alzheimer's is a natural cause of a natural result of aging. So how do we get at the problem of both in high resource and low resource countries begin to get rid of the stigma that somehow dementia is a natural cause of aging, and those that severe dementia are simply experiencing some psychotic condition?
Right. Part of the anticipatory approach that I was talking about before is to provide good information. Now, as we have seen with the pandemic, there's unprecedented access to information. The problem is a lot of that is mis and disinformation. And again, that was not created by the COVID-19 pandemic, but it became much more visible and extreme, I think, when it came to vaccine hesitancy and other elements of misinformation. A good health system acts as a curator of knowledge. And part of what our role is to empower the population, both our patients, but also people in the community, with the scientifically based knowledge that allows them to take care of their own health. And that starts with eliminating the stigma of many of these chronic diseases, explaining that there is a biological root to these diseases. These are not, the other framings about the disease experience, especially prominent when it comes to psychological, behavioral health issues, and that contaminates other brain health issues like Alzheimer's. That element of information and curating appropriate information. The problem today is not so much access to information, is actually making sure that information is the correct information, it's scientifically based. But all of this is a component of the anticipatory strategy and the empowerment of people to be co-producers of their own health. And there we do have now means to do that, and we need to mobilize them. And this is a very different view of primary care than the traditional perspective of an isolated clinic in a remote area with pretty much community health workers. This is primary care as part of integrated networks, where you may be located in a ambulatory facility, but you are connected, because we do have elements of connectivity today that we didn't have even 10 or 15 years ago, connected to all the resources, both the knowledge, but also experts. We still need specialists, but today you can be located in a low technology setting, accessing through telehealth the most specialized person in a high specialty center. We need to move from this pyramidal view of health systems, where you have a base of very primitive care, which is what we used to identify with primary care, and then you have a small apex of high specialty centers, into integrated networks where there is a constant flow of information and intervention among all the elements of a high-performing health system.
Let's just one last question, and we're going to let you go because I know you have a date, so to speak, in a few minutes. What you describe is fascinating, because we're learning that our traditional Western or European and US notion, where you have a big hospital and people come to the hospital for their treatment and detection of disease and treatment. We're finding around the world that there are a number of different kinds of mechanisms, models of healthcare. So community health workers in Kenya or Armenia, Cuba, where you have community health workers that go out into the community, know the family, know more of the context within which that family and that individual lives and experiences life. We're finding that those modes are very, very much more personalized in a sense than the system where we're relying on people to come to a big hospital system. Even in the United States, we have in the Latino community, promotores, where community health workers go out into the community, understand the family context, understand what might be safety and health risks from the environment in which people live. So I'm curious about what you think of these non-European US sort of systems for assessing community health and anticipating and then treating disease.
They are extremely valuable so long as they are connected to the larger health system. I think the evidence is that community health workers that act in isolation, without referral mechanisms, without the appropriate ability to tap into other sources of expertise, do not perform as well. When they are part, they are highly effective. And you are right. Lord Nigel Crisp from the UK authored a book a few years ago called Turning the World Upside Down. And it's a series of case studies of how innovations in health systems from developing countries have made it to rich countries. And the example you mentioned of promotores in the US and others is exactly that. This is what we need, and this is why I celebrate this learning laboratory. It is an opportunity for shared learning. And remember, we are at a time of huge scientific and technological innovation. Innovation needs then to also spread to the way we integrate those or organize and fund and finance and provide access to the health systems, with the technologies finally are put at the disposal of the people who are going to benefit from them. We need to innovate health systems as much as we need to innovate the technologies that power those health systems. And part of that is a new way of thinking about the workforce. Again, it's team-based, it is connected, it's through integrated networks of diversified both facilities and healthcare with an anticipatory mindset, which means going out to the community to look for problems before they show up at your doorstep. That is, I think, the shape of a health system of the future, and one that would be up to the task of facing complex chronic conditions like Alzheimer's.
Dr. Frank, I can't thank you enough for your comments this morning, but also for your service to the DAC board and the Davos Alzheimer's Collaborative, which, as you note, can hopefully start bringing more conversations together so that we all are both motivated and effectively can do a better job at detecting Alzheimer's early. In a context, whether it's community health workers or whether it's centralized health systems, and where we take advantage of your diagonal notion of let's get the primary care out into the community or into each individual, and then rely on sort of brain health navigators or expertise or hubs or something that will bring the best of specialization with the best of primary care. I can't thank you enough for your being with us today and for joining us on the Davos Alzheimer's Collaborative Board.
Thank you, George. Yeah, great privilege.
I'm now pleased to introduce Tim McLeod, co-director of the DAC Healthcare System Preparedness Program, who will moderate our panel with 5 of our 12 DAC early detection grant recipients, with 5 of our DAC grant recipients who are implementing innovations and interventions at the systems level to enable early detection of Alzheimer's. Tim, I'll turn this over to you.
Great. Thanks so much, George. Good morning, everyone from Toronto. I'm thrilled to be here. I'm particularly excited to be able to spotlight the work of my colleagues in the grant programs that George just mentioned. They're doing really exciting and important work that at times is challenging, and they've learned a lot of great stuff. So I think George and Dr. Frank did a great job of setting the backdrop on why health system preparedness is so critical in the Alzheimer's space at this particular moment in time. I'd now like to move sort of a little bit into questions of how. So really looking at the local level, how do we catalyze change towards system preparedness in early detection? And so this morning we'll do 3 things. So I'll give you a little bit of context on the grant programs. I'll have my colleagues introduce themselves and give you a brief snapshot of the programs that they're running. And then we'll spend the majority of our time in discussion, sort of sharing out what these leaders are learning in the field, the opportunities we're seeing to ensure sustainability and scale, and then how these programs are catalyzing change at the local level. So let me tell you a little bit about the grant program and the background context. So our mission at DAC-SP is to ensure widespread global access to novel screening tools, diagnostics, and treatments. And we do that through programs like this grant program. And so not only does this grant program help us catalyze change at the local level, it also helps us really get clear on what helps or hinders adoption in terms of policy and practice. And so when we started our work at the outset of around 2020, we convened a large working group of global experts and really sought to define what do we mean when we say system preparedness in the context of DAC. And so the slide that you see in front of you is that framework. And so it's divided into 3 themes of awareness, activation, HCS, healthcare system patient flow, and access. And so below each of those themes, we've got 10 nodes, each of which has a measurement a measurement associated with it. And so I don't have time to really unpack this framework today. Last Friday, our team published in Alzheimer's and Dementia a paper that sort of unpacks this framework. So if you're interested, I would really encourage you to check that out. So the starting point for our team in system preparedness was on screening and early detection. So as George mentioned earlier, we're trying to catalyze change from a top-down and bottom-up approach. And so we launched a flagship program that uses sort of a common element model that has some adaptation for local context, but is fairly similar. And then to make sure that we were capturing and harnessing sort of local innovation, we started a grant program where we solicited input globally on how different settings would like to run their own programs to increase rates of screening and early detection. And so that's what we're going to talk about this morning. And so while there's a lot of studies that really focus in screening and early detection on questions of effectiveness, there's less evidence around the factors that help or hinder uptake operationally, particularly in non-specialist cares settings across the globe in different income settings. And so we know from empirical research on systems change that novel evidence-based interventions tend to take 15 or 20 years before they become adopted in routine care. And so grant programs like this are so important because not only do they help us catalyze change at the local level, but they help to systematically document what's needed from policy and practice to ensure widespread and rapid adoption. And ultimately, this is really about globally patients and their families benefiting and having access to novel innovations. So that's all the background I wanted to provide the group. And I'd now love to turn it over to my colleagues to briefly introduce themselves and just give us a brief synopsis of the studies that they're running. So Dr. Abu Bakr, why don't we start with you?
Good morning. My name is Amina Abu Bakr, and I am a community pharmacist in the United States. And I also am the founder of Avant Institute that advances community pharmacists to leverage their trust and access to improve patient outcomes. So for this program, we partnered with community pharmacies across the United States to use their trust and accessibility for early detection and screening. Thank you.
Great. Thanks so much, Dr. Abu Bakr. And Dr. Bornbaum, why don't we go over to you in Toronto?
Thank you. So my name is Catherine Bornbaum, and I'm very fortunate to serve as the head of clinical operations and partnerships at ReadySpec, which is an AI medical imaging company that's developing algorithms for detection of Alzheimer's disease through a simple eye exam by leveraging the existing infrastructure that already exists in eye care settings. So our project is a community-based initiative that takes place here in Toronto, Canada. And we use a dual entry screening program, which means that people can come to our program through one of two channels. And we're very, very focused on accessibility, and it's provided at no cost to anyone. So first, we partner with optometry clinics to facilitate access to the ReadySpec imaging. And how we do this is by asking a screening question during the history-taking process. So we ask folks if they have noticed a significant change in their memory over the last year. And if they say yes, then we invite them to take part and have a ReadySpec scan. And then we've also partnered with the Alzheimer's Society of Toronto, where folks can receive a cognitive assessment and then receive any sort of additional services that they might require within the community and sort of ensure continuity of care if it's required. And so one of the reasons you might be wondering why we're working with optometry settings for Alzheimer's disease screening, because it's a little bit atypical from current offerings. It's because we believe in looking to new, novel ways of accessing or reaching people who may not otherwise be able to access services. So here in Canada, we have a gatekeeper model. So primary care must direct all other care except for optometry settings. So we thought it would be a really great way to enable wider scale screening, and so far it's going really well. Thanks.
Great. Thanks so much, Catherine. And Lisa, why don't we go over to you?
Thank you, Tim, and thank you everyone for being here this morning. We're so proud to be part of this project. I'm Lisa Gables, the CEO of the American Academy of Physician Associates. We're commonly known as PAs. We have worked on a project. Thank you for the grant, AAPA, the PA Foundation, and the Cleveland Clinic. We've partnered together to develop a pilot of cognitive assessment toolkit for medical providers in primary care to increase the rates of cognitive screenings in older adults. The toolkit will address key areas for providers, including cognitive screening tools and protocols and training and educational resources to interpret those results, and more importantly, to facilitate conversation with patients. A crucial aspect of this project is that we aim to keep advanced practice providers, not just physicians, up to date with the education and skills needed to perform and interpret these assessments. PAs in particular are a rapidly growing group and a key part of the healthcare industry. Expanding the ability to tackle this early cognitive impairment accurately and effectively can help improve outcomes for patients and hopefully distribute the workload among more providers. Patient-facing practice resources will also be available as a part of our toolkit and as standalone tools for use in any practice setting with any healthcare provider. The pilot implementation of this toolkit conducted at the Cleveland Clinic locations as well as rural clinic sites identified by us will be followed by outcomes reporting and dissemination of the toolkit to a broader audience in all healthcare systems. Thank you.
Thanks, Lisa. And Dr. Mahakian, why don't we go over to you?
Thank you so much, Tim. It's a pleasure to be here this morning. The Brain Health Armenia Project is a countrywide cognitive screening and Alzheimer's disease training program in Armenia. I'm the clinical director as well as gerontologist. And the team consists of a multidisciplinary team of primary care physicians, psychologists, social worker, and clinical nurses. And what we've done is we've created a partnership with a mobile eye care hospital and clinic in Armenia. And the Armenian Eye Care Project is a partner with us, and our team will reach every clinic through the Armenian Eye Care Project. So we have partnered with them to be able to reach more of the adults for memory screening. This is the first time, of course, that such a project has been conducted in Armenia. So we really didn't know what to expect. So we have seen an increase of interest countrywide. And what we've done is our team basically screens 80 to 100 people per week through using the Montreal Assessment Test, as well as we have a demographic questionnaire that we utilize. And what we've seen is that people have a great interest in having their memory screened, and it's been a very successful project to date. We've addressed some of the stigmas through the development of a national radio show, which I'll talk about briefly. So thank you very much for the opportunity to be here.
Great. Thanks so much, Dr. Mahakian. And Dr. Nadetti, over to you.
You can hear me?
We can.
Yes. Just something I just happened. I'm trying to sort it out. But if you can hear me, let me just seek some help.
We can.
Yeah. Yes. You can hear me.
We can hear and see you perfectly.
Yeah, okay, fine. Well, my name is David Dete. I am a psychiatrist here in Nairobi, and Professor Psychiatry at the University of Nairobi. I also directed the African Mental Health Research and Training Foundation, which is the organization that is hosting this program. And I also directed the World Psychiatric Association Training and Research Center here in Nairobi. For us, we are finding this a very, very exciting program. And I would totally agree with what Frank said a little bit earlier on, and that there is need for going all the way to the communities. As a matter of fact, we have already done that. In a previous study, we went and talked to the communities, and in the communities, we talked to everybody. All of us were equal partners in this relationship. We talked to the community health workers, we talked to the family members, we talked to opinion leaders in the communities, we worked together with the policymakers, from the highest level in terms of the governor, the political leadership. We talked to traditional healers, we talked to faith healers, to the clergy, because we realized that here, when people have dementia, their first line of conduct is the clergy or the traditional healers, for the simple reason that they don't quite understand what is happening. They may think this is because of some evil possession or witchcraft or whatever. So we found it very, very important and critically important to involve all of those in dialogue so that they have a different explanatory model. And if we bring in the issue of a medical model, they have absolutely no problem whatsoever in understanding and agreeing that there's another model, not just witchcraft or psychosis or madness, things like that. And we worked with them to develop to agree on a name for this condition in that community, and they said it's very common. And now that they understood that it is a problem that has got a medical model, they had no problem. Of course, we did not necessarily have to challenge them about their models. We didn't want to appear as if we are being antagonistic to them. And let me say this, we're taking that approach. We have been able to throw out stigma out of the community so that they accept this is a model, this is a medical problem, something that we need all of us to work on together. Now, building on that and having been accepted by the communities, the community being very, very receptive, we are going to the next stage. We are going back to the communities, and this time we are not talking about stigma. We are just going to screen for early dementia, memory problems. We hope to screen about 2,400 people. We have already trained the people, the screeners. They are already in the field. And shall I say, for us here in Kenya, we are on the run on this program. Thank you.
Great. Thanks so much, Dr. Ndedi. So I think that this opens up a really great question. So Dr. Ndedi, you told us about how this program is catalyzing change in your health setting, particularly around stigma and sort of how people understand disease like Alzheimer's. So I'm curious, in the panel, how have you seen this program catalyze change in your health setting? And sort of implied in that is, what barriers have you had to overcome? So Dr. Mahakian, I know this is the first of its kind program in Armenia. So why don't we start with you?
Yeah, thank you very much, Tim. No doubt, the barriers that we faced in launching the program was really the stigma and misunderstanding of the disease. Throughout the country, many people believe that memory loss is a normal part of aging. Their beliefs that it was normal to have cognitive impairment is something that we are working on and trying to come up with creative ideas to address it. One way we've solved the stigma, addressing some of the stigmas with the healthcare professionals, was really to look at our training, that a model that has been developed, and to address some of these misbeliefs and myths in the early beginning stages of the training. We also decided, our clinical director, who also likes to think out of the box in Armenia, decided, you know, how can we reach not only the healthcare professional, but also how can we address the family and reach the family? And so her idea was to develop a national radio show all about healthy and active aging. So that radio show has been instrumental in helping us kind of work through some of the barriers. You know, no doubt this project has been a catalyst, but it's been a catalyst for on many levels, not only with our stakeholders, but also with the government of Armenia. So the development of in a few weeks, a national dementia plan that will incorporate some of this specialized programming. Now that we know we have cognitive impairment in the country, we've screened over 2,000 people so far since June, and we can now, you know, create these specialized programs based on what we're seeing. So it's you know, we've come quite a way in 6 months.
Great.
Thank you.
And I just open it up to the group to share more generally about how you've seen this program catalyze change and some of the barriers you've overcome.
I can comment. So we certainly catalyzed change by introducing an entirely new setting for screening by engaging optometrists in our project. So this is a whole new group of healthcare professionals who, while they do have experience talking about certain brain health issues, because the eye is often, it's connected to the brain. And so it's often a mechanism for identifying things like brain tumors or other sort of cerebral events that may be happening. So it's not totally foreign to be speaking about brain health issues, but talking about Alzheimer's disease and dementia in particular is new. And so one of the things we realized very early on is that we really needed to teach optometrists and the team in the clinic how to talk about Alzheimer's disease and brain health in those settings. We've also talked through how we share information, sort of the chain of information. Disclosure doesn't happen in the optometry setting, I will say. So we treat it sort of like lab results. So the tests can be done there, but for our particular intervention, the results are shared via the person's primary care provider, or if they don't have one, we have a nurse practitioner with expertise in cognitive health. And so she will have a conversation with folks and ensure any follow-on care with specialists or whoever she deems appropriate. So we've put in place some of those channels. We're working within the constraints of the health system. We're not trying, we have enough innovation happening with the optometry component. So we're making sure that everything that happens after that is the sort of natural environment here in Ontario. So happy to dig in further, but I'll leave some time for my colleagues as well.
I'm happy to share if we're still on the same question. So when it comes to the community setting, if you think of America, there's a pharmacy around every American within a 5-mile radius. And what we learned from this process is that everyone is relying on primary care to be the primary discovery and be able to walk these patients in early detection. But when we talked to the primary care, they are overwhelmed. Not only are they overwhelmed with the screening, they are also overwhelmed with what to do and really the follow through for these patients that then get early diagnosis. So our catalyst and what happened was collaboration. Now we're getting referrals from primary care telling their patients that you should go to the pharmacy and get this screening. We're using a computerized 10-15 minute screening, and patients are used to waiting in the pharmacy when they drop off a prescription for about 15 minutes. So using that time to educate, do the screening, and then refer back to this primary care. But what we also found is the need for pharmacists to help this primary care, especially those who are not vertically integrated and have all the resources. A lot of our patients in the rural area, underserved communities, they use independent practices that have very limited resources, but that's their main provider. So now the pharmacists are involved in identifying some of the medications that could be contributing to cognitive decline and working together for deprescribing and helping the outcomes for the patients.
I'll follow that, Tim, just real quickly to say exactly what you just said is what we're finding to be a barrier, that we, particularly in rural settings, primary care is overwhelmed. And we have quickly learned that they need as many tools as they can get, but also to work with other providers in the community to make all this really happen. So that's our big finding so far, that people are, hands up saying, I can't do it, help me figure out a way. So that's been our biggest learning so far.
Great. So I think picking up Lisa and Dr. Abubakar on what you're talking about, we're starting to see some really key early learnings come out, particularly around system coordination. So I'm curious from the group if you could share just sort of a short snippet of, what are you seeing as your key learnings from early or midpoint implementation, and then, connected to that, the opportunities you might see alongside those learnings. So Dr. Nadetti, why don't we start with you?
Yeah, can you just repeat that question slowly?
Yeah, for sure. What are you sort of seeing in Kenya as some of the key learnings from early implementation?
Sorry, I'm not getting, maybe the problem with my reception here, I didn't quite get it. I think I may have a problem with the reception, but Just say it again. I'm listening very keenly.
Sure, yeah. So could you share with us some of the early learnings from your program in Kenya as you've sort of got it off the ground?
Oh, yeah. Very happily, I will do so. Our learning is that as long as you involve people in constructive dialogue, asking them what they think, asking them what could be the barriers or the problems in implementing a given program, asking them what they think would be facilitators, making them feel that they own the process, not we who own the process, but that the process is jointly owned right from the beginning, from the grassroots level to the policy level. I think we have learned that if we were able to achieve all of those, then things run fairly smoothly. So it's a question of getting everybody involved, appreciating their contribution, and owning the process collectively.
Right, thanks for that. Other folks want to share some early key learnings?
Sure, I will. I really think too, it's really our helping the primary care physician understand the value of early detection memory screening. What we found is by developing a simple script in explaining what early detection memory is and how that really will begin to address that in a very proactive way, the brain health of that person, the overall health of that person, was something that we've learned, and really helping that physician understand that, memory loss is not a normal part of aging. So that's one of our key learnings is Tim, has really been, developing a simple script and also having the partnership and support of the Ministry of Health in Armenia has been instrumental in the success of our program, and having them reach out to the primary care physicians countrywide in helping them understand this is value and very important for the overall health of the person.
And Tim, if I may share, which might answer a question that was in the chat. So as a pharmacy, when you're starting to get involved, what we learned is before you go out there and start screening patients, it's important to go to your community and educate those providers of what you're doing, because most of them are very afraid of fragmented care. Here comes another provider to this patient's ecosystem, and they know nothing about your scope, or the fear of a patient receiving information that could be contradicting to what plans they have. So we found it earlier when we went to the providers and educated, and I would say the grant really validated the importance of us getting involved. And so they were very easy to listen to, and then see this just like a public health initiative when pharmacists were involved to increase vaccination rates and misinformation in the community because of our access point. Because someone had asked, how will the providers take this when a pharmacy, we are not diagnosing, we are just aiding in the education and getting the early screening and referring them back to these resources in the community for the proper diagnosis.
Yeah, great. And Catherine, I see you nodding along. I know that your program similarly uses and community-based access points. So wondering what you would top up on in terms of learning.
Yeah, I definitely echo those same things. And we do have specific initiatives to educate providers and provide information as we share the cognitive assessment results. I think the key things that we have learned so far is that it's really important to keep it as easy as possible, as low burden as possible for the health system. So that means understanding the workflows of the partners that you're working with and making sure that any additional things are very simple and work within the way that they already interact in the clinic flows and information flows. So you really want to just work with what's already working, not add to that. And the other thing that we've really learned is that it really works. Optometry is a really great way to identify or to facilitate early detection. I think because our technology already leverages cameras that exist there, so we're not adding new components that people aren't already familiar with. And the workflows are very simple. It's been really, really effective. And actually more than 75% of the folks who've been screened have been screened through optometry settings, which is not necessarily what we expected, but we're delighted. So I think there's some real promise for this type of setting. It's really exciting.
Great. So we've got 4 or 5 minutes left. And so I'd love to sort of just do a quick round with the group on scaling and sustainability. So you've all been working really hard. I know there's a lot of barriers to overcome in standing these programs up and a lot of siloing. So in your opinion, given what you've learned so far, what do you think it will take to make your programs sustainable and scalable, both within your own health system, but potentially for other geographies? And so sort of in short, what's your call to action? Lisa, why don't we start with you?
Thanks, Sam. I think the one thing we've learned, and we've just heard it now from everyone, is that it takes a village, so to speak, to make this all work together. That the partnership between community-based organizations, other providers, the healthcare system, clinicians of all types is really critical in the aspect of making sure that we're getting full, proper care for the whole person here, and the family caregivers that are really important to this process as well. So we believe that if we've done our job right here and to make this scalable, we'll create a comprehensive model that works. Secondly, the toolkit that we're creating for PAs, and someone asked the question, NPs, yes, too, and all clinicians actually, pharmacists and everyone, is that the materials we're developing are dynamic and adaptable to the place in which they're being used. And one thing I just want to point out that we learned very quickly is that a patient who is diagnosed by a PA of having cognitive impairment is scared. Right? We all know that feeling of dread when such a diagnosis occurs. And so we felt it's very important to create materials that the patient and the family can take home to absorb. It's in the proper health literacy context. So that's very important. And so we, and of course, to have things translated into many languages is another thing that we learned very quickly. So it's important to make sure that at the end of our project, we have done that work. So I think it's a collective effort is really what I would say. Thanks, Tim.
Thank you. And Dr. Mahakian, why don't we go over to you? What's your call to action around scale and sustainability?
I was thinking, Lisa, it certainly does take a village, and we are certainly in those villages throughout Armenia. What really we've seen and what it takes is really, now that we have clarity on the prevalence, starting to have clarity on the prevalence of dementia in the country, cognitive impairment in the country, we're now better able to address the development of appropriate programs and services and initiatives. So sustainability with programming for the near future will be to expand this project, and we're going to expand it to better meet the need of ongoing long-term need by creating a innovative home health care program that not only is meeting the need of the patient or the person with memory impairment, but also their family, the family caregiver, through all stages of the disease, including palliative and end-of-life care. So we can see that, developing this model is really changing and it's changing systemically throughout the country. So basically, another sustainable project within the Brain Health Project is the development of memory cafes throughout the country. And our plan will be to develop a memory cafe in every region of the country.
Great. Thank you so much. Dr. Nadetti, over to you. What's your call to action around
Now
scale
I can,
and sustainability?
I can hear you very well.
Oh, great.
I think what we are seeing here in Kenya and we are planning to do is that we are very aware of the importance of sustainability beyond a given program. And the way we do it here in Kenya, which is what we are trying to do now, is to try to integrate this into the already existing system. We are using community health workers, we are using government facilities. They are seeing as part of their work, so that if they can demonstrate that it works, it will seamlessly be part of the existing health system. That is why we work with the policymakers right from the top, and even at the national level. At the national level, they already know what we are doing. We have fantastic support at the regional level, and they know that what we are doing is not just for us, it is their program. And this is what I keep on saying. It's not our program, it is their program. And I think that way we'll be able to achieve sustainability. That's what we are planning to do. I think for us, we are seeing this more or less as a pilot. We are using at least 2 screening instruments. I think we'll come up with one that can be easily administered, and we'll maybe put it on a platform so that we can reach as many people as possible. Of course, if we do that, we run the risk of creating demand more than we can provide the services. But I would rather have people coming for help rather than sitting with a problem and they don't know that there is a problem. So that is our strategy. And our long-term strategy, as I say, integration and nationwide adoption for at the national level. Thank you.
Great, thank you so much. Dr. Abubakar, what about you? What's your call to action for scale and sustainability?
Sure, my call to action is if we can get the insurance companies to recognize alternate sites for screening and not diagnostic, but screening. So because they're the ones who can run the query of how many people at the age of 60 and above have not been screened because of the billable codes that they're able to identify, and then giving those patients options of alternative sites that have minimum standard requirement of what screening is about, and then referring to their providers, to appropriate providers. Very similar to what we learn in vaccinations. Pharmacies are now the ones really driving the vaccination rates because we're able to screen through the registries and for patients who haven't gotten these vaccinations. So I think that would help scale, because right now we're doing it through the grant, but what happens after the grant?
Right, thank you so much. And Catherine, what about you? What's your call to action in Canada?
Thank you. So Canada is not unique from any of the countries represented in this conversation and on the call, in that the wait times for cognitive assessments are months or sometimes years in length. And what this means is that people oftentimes are taken to a point of crisis where they then are able to access care. And quite frankly, we can do better, and we have the tools to do so. So what I think we really need to focus on is finding new and innovative ways that we can enable those with a cognitive impairment to access care. And so, you know, from our perspective, this means leveraging novel settings such as optometry and pharmacy, ensuring that there is appropriate reimbursement and that scope of practice may be expanded in order to allow this at a scalable, in a scalable way. but to really lean into the resources that we already have in place, and to leverage that sort of policy and infrastructure working together to enable broad accessibility. So I think there's an important role for government, healthcare, and industry to work collaboratively and to think a little bit outside the box, because what we're learning so far is that it's working very well and that people are actually flowing through and receiving follow-on care. And so I think there's a real case to be made for expanding our current modalities and locations that we're working with.
Great. Thank you so much. So we've reached the end of our time for the panel. So I really want to thank our panelists for calling in and sharing sort of a half hour of their morning with us and being so generous with sharing their learnings. Particularly Dr. Mahakian, who was online at 4:30 a.m. PST. So thank you so much.
Thank you, Tim.
So it's my pleasure to introduce our next speaker, Dr. Megan Eldred, who is a senior policy advisor with the Dementia Mission Lead for the UK Office of Life Sciences. We look forward to hearing her perspectives on the role of government in supporting, strengthening, and building capacity of health systems to better support individuals affected by Alzheimer's disease and the urgent need to prioritize investment and smart policies to ensure sustainability of Alzheimer's research and care. So Megan, over to you.
Hi, Tim. Thank you for your introduction. And thank you for having me here. It's been fascinating to listen to all of the other speakers before me. So I'm going to talk a little bit about the work that we're doing in the UK government, focusing on research and innovation in dementia. And so I'll start with a little bit of context in that the UK to date has already been investing quite a lot in dementia research. I think in the last 5 years, it's spent about 420 million in this space. And we do have sort of various government research funders. So we have the National Institute for Health Research. We have the Medical Research Council that provide a lot of this funding. And it's also set up some sort of world-leading research institutes. So we have the UK Dementia Research Institute, which had 190 million pounds of funding, and also some co-funding from some leading charities in the UK, such as Alzheimer's Research UK. And so I think we invest a lot into sort of good basic research and understanding the fundamental sort of mechanisms but underlying various diseases within dementia, particularly in Alzheimer's. And we do some work in the translational space, but there's a lot more that we can do, and particularly to try and sort of pull some of this research through from basic research through to clinical research. And so last year, the government launched the Life Sciences Vision, which sort of talks broadly about what the government is doing to kind of bolster the life sciences sector in the UK, but it also outlined a series of healthcare missions. The dementia mission is one of the pioneering missions within this. And so since it was launched in the Life Sciences Vision, we've been doing quite a lot of work to sort of understand where the government can best get involved to try and sort of improve research and clinical research in this space. And so, sorry, I didn't introduce myself, but I'm the Dementia Mission Lead within the Office for Life Sciences. So I've been trying to work to scope this out. And the mission was actually launched by the Prime Minister in August this year. And we've been working very closely with a vast array of stakeholders in the UK, but also internationally, to understand what it should do. So we do now have an agreed vision with industry, academia, other research organisations, the NHS, which is our healthcare system, and others more broadly. That the UK Dementia Mission will focus on two main areas. One is biomarker development. So we're not discriminating between wet biomarker or digital biomarkers at this stage. And then the other area is investing in our clinical research infrastructure in the UK. And that investment will be coming through the NIHR, so the National Institute for Health Research, which already has some infrastructure in place, but this will be quite a significant increase in funding. So overall, the government backing for this is 95 million. but we are hoping to leverage additional funding, as I'll go on to explain in a moment. The overall aim of all of this is to try and pull through really promising research through to translation and through to the clinical research platform, so that we can speed up and de-risk clinical trials in dementia and try and deliver drugs to patients sooner than otherwise. So how are we going to do this? So we're working closely with industry on one of the elements, so that's the biomarker development side of it, to understand where are the key sort of bottlenecks at the moment in the drug development pipeline. And we understand that these are in patient recruitment and stratification, understanding that we have the right sort of the right understanding of where a patient is in their disease trajectory, and that they are being placed in the right kinds of trials. Our understanding of how a disease changes throughout the time that a person is in a trial, and then getting better measures as endpoints of trials. So if we can have better measures that we can use sooner, then that will help to de-risk these trials and reduce cost as well. The other element, the clinical trials infrastructure, will be looking at increasing number of sites across the UK, increasing capability, and increasing patient recruitment and phenotyping of patients as well. Because we have this sort of all badged as a UK dementia mission, it also provides great opportunity for us to not only join up the research ecosystem within the UK, but also to act as an interface with international initiatives as well, such as Davos. And so I've already started to have some conversations with colleagues that are on the call today, and I think everybody is really quite excited about the opportunities that we can try and exploit through this mission. So finally, I'll just sort of wrap up in terms of what sort of impact we expect to have, not only for drug development and clinical research, but also on the healthcare system in the UK in particular. So initially, we obviously want to increase biomarker availability for those key kind of pinch points within drug development. So patient recruitment and phenotyping, and then also having a better measure during clinical trials. The benefits of this would be seen not only for UK research, but these biomarkers could be used globally. That we have sort of a big objective to try and join up the UK research ecosystem. So we do have some really good institutes already in the UK, such as the UK DRI and Dementia Platforms UK. This is a really great opportunity to try and join those up and increase the sort of appetite for people to come and do their research and run trials in the UK. We have an opportunity to work with the UK regulator. So that's MHRA, the Medical Health Regulatory Authority. And, you know, we have an opportunity as government to actually work with them to show them the benefits of using biomarkers in assessment of drugs, but also to make sure that we're developing biomarkers in a way that is acceptable to them and that produces the right kind of data to show efficacy. And then finally, the impacts on the NHS. So naturally producing these biomarkers, they would have some application to diagnostics and also sort of monitoring of patients within the NHS and care settings as well. But there come a lot of challenges with this as well, which I've been hearing from other colleagues on the call, and these are not unique to the UK either. And so this is not necessarily my area of policy, but I'm happy to sort of provide comment where I can. But the recent announcement of the lecanemab drug has certainly sparked conversation in the UK around, well, what does the NHS need to do to prepare to, firstly, it needs to be regulated, but what, you know, if it does get approval, what does the UK healthcare system need to do to prepare to give patients access to this drug and to support them through their treatment pathway? And there are significant challenges in this, one around diagnostics. So we know that this drug requires PET scanners, and the other potential drugs coming through the pipeline also may require CSF samples. There are challenges with this, as others have been discussing. In the UK, PET scanners are still not ubiquitous across the system, and they're very expensive and require skilled staff to operate them and interpret the results. So this would be a significant challenge for the NHS. And then CSF samples are obviously quite invasive. And so one of the benefits of the biomarkers that we want to develop through this mission are that if we can develop biomarkers such as blood-based biomarkers, this would alleviate a lot of the challenges for the NHS in terms of diagnosing and monitoring patients. And then, you know, it's helping to move on the field more generally, which everybody's very excited about. And then finally, the model that we want to work through, which is a sort of deep collaboration with industry, academia, and the healthcare system. We really hope that we can harness the learnings that the UK garnered during COVID, particularly through the Vaccines Task Force, to really understand how we can drive this forward at a faster pace than would have happened otherwise, and to really pull together assets and funding from various different partners. And really keen to you know, share those learnings, but also learn from others who are doing running similar partnerships around the world. And so, yeah, great to be here. Happy to have an open conversation, and thank you.
Thank you, Megan. It's George Vredenberg again. Just a couple questions. We just have a couple minutes here. One of the great challenges as government funds increases funding in an area is to assess how to assure that those funds are productively used. And so setting some goals and some targets and some measurements and those kinds of things is always difficult with governments, because you have changes in administration, you have changes in execution on existing policies. But I'm curious, because you have basically outlined the right agenda, it seems to me: investing in faster innovation, making sure clinical trial infrastructure is both there and performing well and faster than it has in the past, and getting all those innovations into the population via changes in the health system. When I was there in 2013 with Prime Minister Cameron, we set a goal at the G7 to actually get a disease-modifying drug by 2025. 2025 is coming upon us. We have the possibility of having a disease-modifying drug by 2025. But I'm curious as to whether any of your work is driven by either that goal or some other measurement in terms of penetration of diagnostics, diagnostic rates, some other kinds of measures on how to, as you say, improve over what currently exists in terms of pace, speed, and innovation.
Yeah, so the ambition set out in 2013 was actually one of the driving forces behind the establishment of the UK Dementia Research Institute, which I've mentioned. So that institute has done great work. It's produced a lot of sort of scientific discoveries around the fundamental understanding of the disease, but also some translational work as well. And I think we're moving into a different phase in the UK now, in that we're really seeing that we need to pull this through more and into the clinical space, and to kind of build the clinical research infrastructure to support that. So I think that's sort of where we've progressed since those original ambitions were produced. And then, you know, back in those days, we didn't know if we would have a disease-modifying treatment available. So that is obviously a sort of new conversation that we're having with the healthcare system now, in terms of how do they prepare for that. But it is a huge challenge for our healthcare system. I don't know the numbers, but you know, if every sort of eligible person was able to receive this treatment, it would be, you know, a significant impact on the healthcare system. And so I think they need to think really carefully about how they manage that. And so that's going to take a little bit of time to think through.
Well, it's an excellent point. You're caught on the horns of the dilemma. You can't afford to reimburse for the medicines because they are expensive and the population is large. And yet, if we don't do anything, we just see this growing prevalence of the disease and cost to society. So we have some major challenges in front of us. But thank you very much for your time. Thank you for your commitment. Thanks to the UK for its leadership going all the way back to 2013. It was remarkable at the time and really set sort of the world a bit back on its heels in terms of really trying to challenge this disease. Your comment that we're all sort of underdeveloped countries in a sense when we're talking about this disease and diagnosing it, and then finding effective and affordable ways to get the population a disease-modifying drug is spot on. We're all in the same boat. So thank you for your time. Thanks to the UK government for putting you where you are, and thank you for doing what you're doing.
Thank you, George. Thank you for having me. And I will be intently listening to the further conversation today.
Great. So I It's my pleasure now to introduce our next keynote speaker, Renee Wegerson, the first director, the inaugural director of the Advanced Research Projects Agency for Health, or ARPA-H, here in the United States. I look forward to her remarks. A number of us in this country have been advocating for the creation of ARPA-H. ARPA-H is now set up. We have our inaugural director, and now, of course, she's probably there with a desk and one person, given the fact that she's only been there a month or so. But nevertheless, there's great promise in this agency, which, like our Defense Advanced Research Projects Agency in the United States, was charged not with making a faster plane, but making planes invisible, not with just another satellite system, but making a satellite system able to speak to our cell phones. So it is a transformational agency potentially, but it's an enormous challenge. And Renee, with her background, is up for it. So I am looking forward to your remarks, Renee, and then I'll ask you a couple questions.
Terrific, George. Thank you so much. It's such a pleasure to be here and to share a little bit with you about ARPA-H. This is going to be different, perhaps, from the very focused discussion that we've had so far on Alzheimer's disease. What I'd like to introduce to you, as George mentioned, is a brand new agency in the United States government that is going to pursue a disease agnostic approach, but really ARPA hard challenges to solve the well-defined problems in health, which could include challenges in neurodegeneration and Alzheimer's disease, which are actually really close to my heart. I worked on my PhD and postdoctoral research in protein misfolding disorders and spent some time in industry developing diagnostics for protein folding disorders. So let me tell you, I don't have a lot of time today, but I do want to get you at least familiar with the charge in this organization that I've been set out to lead as the first director. This is just week 9 for us. So we have a website that you can come and land on, and I'll share that address with you in just a bit so you can learn a little bit more about our mission. But more importantly, we are hiring program managers who will be the folks that administer the funding and the grants that come out of our organization. And so this engagement with this group is really call to act. Like to see the projects that are be funded by an ARPA. We need those program managers in place first before we can start to fund those projects. And so think about those 1 or 2 folks in your network that would make a really great program manager to bring forward to this agency. So as George mentioned, we're modeled after the business model for the Defense Advanced Research Projects Agency, which is now a 60-year-old organization and has brought us innovations such as the internet, mRNA vaccines, and things like stealth technology. So if you would have asked the founders of that organization, tell us what the big things you're going to do are. The organization was launched in response to Sputnik, and they couldn't have imagined that they would move forward with stealth and beyond. So I want to humbly say my role is to really create the culture and organization to pursue our mission, which is singularly to accelerate better health outcomes for everyone. And in doing so, I hope that we can launch whatever might be that future DPS technology or stealth technology for health. If you go to the next slide, I think it's helpful to just understand where ARPA-H sits within the health ecosystem. So we are not here to replace anyone, but instead be a catalyst, an accelerant to bring new concepts forward and really de-risk them. So having something be funded at ARPA-H is a really special situation where the risk is too high for maybe big pharma or for another federal entity, whether US or beyond, to be funding it. And ARPA-H is here to de-risk that project in a transaction to bring down that risk. And then we would transition those projects out to our stakeholders. And really, the right side here, we show our stakeholders, which could be other components of the National Institutes of Health, actually report directly to Secretary Becerra for those in the US system. He's our lead for Health and Human Services, but we do lean on the infrastructure of NIH. We don't bricks and mortar, but they're helping us set up our IT technology. FDA for regulatory, CMS thinking about pricing and equal access. These are all really key stakeholders for us as we move forward, as are NGOs and others that may be in the global health forum who can help us transition some of our technologies. Our customers, importantly, are the public, their healthcare providers, their patient groups. And so many of the folks represented on this call today, you will be our customers and also be some of the folks who can best help us understand what are the big problems that only an ARPA can solve in this specific area as we focus on Alzheimer's disease. Our performers, or those that are funded by us, will be primarily academia and industry. If we go to the next slide, I've outlined a few specific mission areas that we think that further investment in health can really move the lever and help us disrupt and get to the next advances in a disease agnostic way. And so you can look at this through a lens of Alzheimer's disease and neurodegenerative diseases, but the intent here is to broadly enable tools, technologies, and platforms that can support a broad swath of diseases. So the Health Science Futures mission thrust area, this is where you can really think about some of the hardware tools, some of the molecular platform tools that we'll be innovating to accelerate advances and just expand the art of what's technically possible. And so, you know, you can think about things like DARPA really accelerating the development of mRNA encoded antibodies and antigens. What are the next generation type of molecular tools that ARPA-H may be able to enable? Scalable solutions. And so this is really a mission thrust area that is going to be focused on, there may be some proofs of concept out there, but getting them where they need to be, whether it's a rural setting or to a low-cost setting, or somebody that wants to use a tool at home instead of having to go to a clinical center. What do those look like? Imagine if you could do a PET scan in somebody's living room. What would that enable for this community, or a finger prick test for Alzheimer's disease? These are the types of scalable solutions to get to the broadest swath of folks that we want to focus on. Proactive health. This mission area is really focusing on keeping people from becoming patients in the first place. And so what are the early detection and diagnostic capabilities that we have here? What are the behavioral and social types of innovative programs that we want to pursue to prolong individuals' longevity, but also their best, healthiest life possible? And then finally, resilient systems. This is really an area where we think there's an opportunity for massive systems integration across health. And so there's been a lot of funding that have gone into diseases like Alzheimer's disease and cancer, but a lot of the progress can still remain within silos where that information isn't shared in a way that can reach the broadest number of patients quickly, or healthcare providers or innovators to really capitalize on that investment. And so we like to think of this mission thrust area as just a silo breaking off, as somebody to put in a focused effort. Programs that we're going to fund across these offices should range between $50 and $150 million. So they're big bets to try to really advance the state of the art. So really, again, encourage you to think about the lens of problems that you face across these areas, and who are the program managers that can come to ARPA-H to pursue some of these concepts. If we go to the next slide, I think a last comment on our model and how we start a concept and start to pursue it. There's two key pieces. We talked a lot about the challenge that we want to be able to solve, that we would call ARPA hard, that can't be pursued elsewhere. But the other key component is the program manager. And so we like to say the program manager CV in one hand, and the other hand is the idea. It's a combination of the two that come to ARPA-H to launch a program, and then seek that community and performers, which may be academic or industry or government research labs, to bring together a suite of a portfolio of solutions to try to solve that problem. Not every solution that's brought to the table will succeed. We have a high tolerance for failure, but we will very actively manage these programs. So if something isn't working out, we can stop one line of pursuit and be able to pivot those resources and bring that to bear on another concept. And I want to just give you one notional example. We don't have program managers that we've hired yet. Again, this is week 9 for us. So we anticipate the first quarter of the next calendar year to be bringing on those program managers. But here's just an example of something we've heard from the community as a common problem across a number of diseases, and that is histopathology. So the ability to look 3-dimensionally at tissues, to be able to look at something like tumor progression or the growth of plaques and things like this, is something that is not automated today, and we think is ripe for AI and machine learning innovation to be able to quickly quickly analyze and automate the diagnostics and interpretation of that histopathology information, to integrate that data and make it in a shareable format so that we can all learn from that, and moreover create the next new novel multi-omic histopathology assays. If we had a program manager that would come to ARPA-H to develop a program around this concept, you can imagine investments in teams that bring together those assays, that AI ML approach, and the data integration. And we could have several shots on goal, and they could be looking at indications that might include metastatic cancers, but might also include things like Alzheimer's disease and wound healing. And so that's really how you should think about ARPA-H, as a tool developer, a platform developer for a broad swath of diseases. And if
Well,
we go to
Renee,
yep.
Renee, it's very exciting. What you're going to do is very exciting. And clearly, it's taken us 6 years to get there with DARPA. Hopefully it'll take us fewer years to get there with ARPA-H. But nevertheless, what you have in scope and in imagination is really really exciting. So thank you for coming. Thank you for all of the the resources here to get us engaged with you globally.
Great, and here's a way to connect with us afterwards, George. So there's a website I hope everybody can check out and stay engaged. And please, there's a landing site for program managers who I hope somebody from this community, more than 200 people on the call. There's some brilliant minds here that we would love to work with to advance some of the goals discussed here. Thanks again, George.
Just one quick question,
Yeah.
because it's relevant to this group, and that is as you think about your problems, are you thinking globally, or are you thinking US only?
Absolutely globally. So health impacts all of us, and we seek solutions all across the globe.
Well, I appreciate that, and there are a lot of obviously people on this call that might be interested in applying for a job. So we thank you very much for doing what you're doing, and thank you for taking on this task. It's you're going to get bombarded with both opportunities and criticisms for not moving fast enough. So just anticipate the bruises and the excitement at the same time.
Absolutely.
Thanks a lot for coming, Renee. Appreciate it.
Take care. Bye-bye.
It's now my pleasure to invite my colleague, Phyllis Farrell, our co-director for the DAC Healthcare Systems Preparedness Programs, to join me and introduce our next speaker. Phyllis, it's yours.
Thanks, George, and thank you to Renee. Obviously, the establishment of ARPA-H is an incredible milestone for the US, but I'm thrilled to hear her say that they also have a global remit. I hope this is the first of a long-standing collaboration with ARPA-H and DAC. But it's my pleasure to actually introduce Tarun Dua, whom we have a long-standing collaboration with the World Health Organization and DAC, and specifically with Tarun. Tarun was part of our very first work group that started in January of 2020, right before the pandemic closed down the world. It's just hard to believe how much has happened since then. So Tarun is the medical officer of the Department of Mental Health and Substance Use at the World Health Organization. And it's so lovely to see you, Tarun, if only in 2 dimensions. Today, we've heard from our amazing partners and grant beneficiaries, and I just loved following the chat. Honestly, we probably could have done a full session just with our grant beneficiaries. But we also heard from Julio Frank, we heard from Megan and Renee, and now you're here with me to kind of pull it all together at the end. So while I've got you, and you look to be on mute right now, so I may have you come off mute.
I am unmuted. You can hear me well?
Oh, okay, we can hear you now. Great. Okay,
Yes.
good. I'm glad you're here. So we know that many countries around the world are still challenged with raising awareness of Alzheimer's disease. We heard this about stigma and awareness with our grant beneficiaries that are working on the ground. When we think about early detection, in your opinion, how can we couple this early detection and screening with better understanding and awareness of individuals with Alzheimer's, related dementias, or any cognitive impairment. What can be done about this, and what strategies should we be considering?
No, thank you, Phyllis, and my pleasure to be here and bringing some global perspective, bringing some of the strands that we heard today together. Now, clearly, awareness raising is a key strategy for improving detection rates, and I'll give you a couple of examples on why. So when we are thinking about early detection, it is through healthcare providers, and in many parts of the world, we know that healthcare providers, they think the primary healthcare providers, then nothing can be done about dementia. So I think that's one part. So if we really want to them on board, raising their awareness is going to be extremely important. They have to be part of the solution, right? So that's one thing. And then secondly, of course, we know that we have to have that demand, people, because of stigma, their attitudes may not come forward. And then if in a sense, we have both, it works. If you have increased demand, you have to have increased supply. You know that business model more than I do. And if you have to have increased supply, you need to have some demand. Otherwise, what are you going to do with that? So those are with those two issues, the capacity building of non-specialists. In high-income countries, we hear about more about the specialists. But if you're thinking about the non-specialists, and you heard some of this today when we had people speaking from Kenya or other countries, and what we have seen, when they are trained, they feel empowered. They feel that they can do something about it. And I think that's something that we need to do about it. They feel good. They feel they can make a difference. The other part that I would say is that as we think about this is involving civil society, people with lived experience, and being champion in that awareness raising. Let me call out Alzheimer's Disease International for the good work that they are doing, but then there are many other national level association societies that can take this work forward, and we have seen this in HIV. That's a good example of where it helped. From our side, capacity building, if we are thinking in terms of non-specialists, we have our MHCAP intervention guide, which takes an integrated approach and includes dementia. These are the evidence-based guidelines, algorithms that are available. So I think these are some of the strategies that can be undertaken at national level.
I love that when you talk about awareness, you're not just talking about patient participation, consumer awareness, you're talking about physician awareness as well. And one of the things that's just been really interesting as we've been looking at these grant beneficiaries and flagship projects that are actually on the ground is actually how similar we are across high resource countries and low and middle income countries. And in fact, right now, we're finding that the percentage of unrecognized cognitive impairment is the same in Armenia as it is in the United States. Earlier it was mentioned we're all a developing country, as it relates to Alzheimer's disease. I think this idea, though, of disease modifying therapy and the fact that it's only worth diagnosing when there's a disease modifying therapy is really a high resource constraint. We've heard it a little bit in the chat. We heard it a lot in our programming. And in fact, I think one of the things that surprised me the most is how fast some of our low and middle income countries have come on board with screening and early detection, because they really look at the social impact of making sure that families have the support they need. And I just love the fact that, we've actually got sharing happening, going both directions between high resource countries and low and middle income countries. So good examples there. So you mentioned about kind of workforce capacity, and specifically, primary health care is our gatekeeper. It's the entry point for better dementia diagnosis and treatment. What are the challenges that are currently existing across countries? We've heard some directly from the beneficiaries. What's surprised you or excited you, and how do you think the WHO might take some of these learnings and help us scale?
No, I think, we have been talking about primary healthcare for many, many years now. I would say that within the sustainable development goals, there has been a recent push towards universal health coverage. I think also with COVID-19, we have seen that the disruption of services happened, and it was more for chronic conditions that got neglected. And countries are recognizing that their systems are not geared to support chronic conditions, and they need to invest quite a bit in that. And I would say that there is, a two-pronged approach that is needed, that the countries need to take forward. One is the strategic levers, thinking about governance, policy, leadership, and we know many countries either do not have a dementia policy or a plan, or either standalone or integrated. So that's political prioritization, governance, resources, funding. That's extremely important. The second is the operationalization, because we also know, and we have heard, that some models, they work at ground level. They are efficient, they are effective, they are cost effective. And, so as we talked about the training of the workforce, the other thing is that how do we take forward digital technology? Again, bringing in COVID-19, we used a lot in terms of telehealth, digitization. How do we take that forward? How do we strengthen care pathways? We heard again that how care pathways are fragmented. There is no referral happening, or there is no consultation, there is no multidisciplinary support. One of the things that people working in the field of dementia, they say, and I truly believe that if you can gear your health systems to support people living with dementia, their families, you can take care of all chronic conditions. So if that should be the benchmarking that the health systems should be doing. And last point is that the research funding and the research work should be PHC oriented. And I think I'm glad to see that the work that DAC and you guys are doing is taking that. We are hearing about some of the health systems model that are emerging from all the work that is being funded.
Yeah, certainly we are trying a lot of different models, recognizing that there's probably not going to be a one size fits all. But we have definitely heard that primary care physicians will say, especially in the United States, if you can help me treat some of the other conditions, say diabetes, cardiovascular disease, the conditions that they have quality metrics that they're remunerated upon. And, we all know that someone who has unrecognized cognitive impairment is probably not going to manage their diabetes very well. We also know that families have support services available to them that they're not tapping into because those conditions are unrecognized. And I think the primary care physicians have a really good appreciation of that. So you talked a little bit about digital. I want to dig in just a little bit there. Obviously, we're using digital cognitive tests as part of our flagship site interventions, and some of the grant beneficiaries are. What is your thinking about technology actually being able to do some task shifting, potentially either getting to lower cost resources, in countries where there are high cost resources available, or in some cases, like our program in Jamaica, where I think they have one neuropsych for the entire country. How do you use technology to be able to scale and get some of this better care where some of those human resources aren't available? Is that something the WHO has been thinking about?
Thank you, Phyllis. Yeah, I think the world has opened up quite a bit to use of digital technology, COVID-19 has, I would say the silver lining of COVID-19 has been our acceptance and evolved the way the technology has evolved. And it can be across the whole care pathway, right? You talked about the digital screening instruments, but technology for awareness raising, how do we use social media effectively? We have seen that. Technology for supporting caregivers, you know about our WHO's iSupport program, which is technology based. Technology as telemedicine, telehealth, for example, you have a scan. Sometimes it is easy to set up an MRI machine, but not have a technology, a radiologist to read it. But then this makes life very easy, that it can be read, it can be discussed, as we are thinking in terms of those technological solutions. So I feel that we need to use technology across the whole care pathway, whole continuum of care, making this multidisciplinary care really possible, but also, but not to do it blindly, right? Every country, every context is very different. It should be culturally tested, acceptable, and embedded within the health information systems. More and more countries are moving towards electronic health records. I think it will make the data monitoring also easier if we are able to move and take forward some of these technological innovations that we are seeing in the field.
I think that
Okay, so I lost my moderator, Phyllis.
I'm back. I'm back.
You're back. Okay.
I don't know what that was. That was just because we were talking about technology, I think. The technology gods wanted to make sure we knew they were in charge. No, I do think this idea of even telehealth, right, in the United States, that was something that all of a sudden mental health awareness and mental health testing wasn't approved in telehealth, and now it's going to continue. So I think there's a lot that we should make sure we grab hold of this pandemic and keep, not the least of which is that it has uncovered for us a real gap in caring for older people in this country. So one thing that I want to just make sure I reiterate that you mentioned. That
one
DAC
point, Phyllis,
Oh,
sorry,
yeah,
before, yeah.
No, go
I
for it.
think one of the things that I just came to my mind, as you mentioned, is that, this is also, as we think about drugs, as we think about other treatments, there needs to be a good ethical and regulatory structure, a framework and standards and benchmarks for use of technological innovations. Some work is happening, but I think that's something that I feel is something we should be investing in. Sorry, I just
no, I'm glad you brought it up. I think the other comment that you mentioned, which I think has been learned out of Gavi and CEPI, and one of the things that DAC is really focused on building on is this idea that you might have some global imperatives of kind of what good looks like, but everything needs to be locally adapted. And cultural relevance doesn't just mean translating the language. It means, how is the work completed? What is the workflow? We know sometimes these large global imperatives can actually cause a lot of disruption on the ground locally if things have not been designed for the local workflow. And I think that, that has to do with interventions, biomarkers, digital tests. Those specifications may be very different based on the local country's needs. So I am going to bring us home. The one thing I want to do is note that we have a comment from Nigeria in the chat that she wants, I think it's a she, I can't tell for sure, wants help in gaining awareness. So one thing I will note is that when these first round of early detection programs are completed, you guys met Tim Litcloud earlier, he and the team are actually going to be putting together an enduring toolkit that will be open access on the web with both case studies as well as individual tools and resources so that any country around the world will be able to pull those down. So we will absolutely make those available. So Tarun, one final question for you before I hand this over back to George. You've got a wonderful platform of individuals today on this call. I think we had over 500 people registered from 35 countries. What's your call to action to this group? Let's give you that platform.
Thank you, Phyllis. Quite a few call to action, but let me focus on a couple here. You have seen from our global status report that we are very much behind targets. So I think I'm hoping with DAC, with others, all we are able to take forward the dementia agenda much more and above and beyond on what's happening at both national level, regional level, global level. Two, we have also seen that there is, in terms of, as we are thinking in terms of investment that's happening or the research that's happening, there's still fragmentation, and we need better coordination, better collaboration going forward. You've seen our blueprint for dementia research, and I'm hoping that more and more research can be coordinated to generate the outcomes that is needed. And last point, is that we need to have better data. I think countries need to invest in giving us better data, because that will help for every aspect, whether it's for policy, planning, service delivery. So those are kind of my call to actions, and this requires all stakeholders to work together, including involvement of people with lived experience. I think this has been the important thing within the dementia field, and we need to do it much more, much better. And back to you, Phyllis.
Thanks, Tarun. We couldn't agree with you more, and are so thrilled that you and the World Health Organization have been such amazing partners for us. There's a reason that we name this the collaborative, and that is because none of us can do this alone. And so one of the things that I'll say as I turn this over to George, you guys have heard about the DAC system preparedness work stream today. That's what the Learning Lab is focused on. There are two other work streams, but the big message is there's room at this table for everyone. So come join us. And Tarun, thanks to you. George, I'm sending it back to you to close.
Well, thank you very, very, very much. We've heard today a really kind of a comprehensive look from Julio Frank's call for the noted the health revolution in terms of longevity. And with that has come a real growth and prevalence of chronic diseases, including Alzheimer's. His call to strengthen primary care, potentially by extending it to other front lines of care. And we've heard a lot of examples from our grant recipients in terms of how they're doing just that, how they're connecting so many more elements in an overall health approach than simply looking at the health system, whether it's from the ophthalmologist's office or primary care providers below the physician level to pharmacies, to community health workers. And so that was quite impressive in terms of extending the front lines of care. That was terrific. Our grant recipients gave us a wide variety of different approaches to how we are extending the front lines of care and addressing new potentially connected models that will strengthen primary care by enabling potentially access to healthcare navigators or health care centers with higher levels of expertise, as it were, so that we can both take advantage of the primary care physician's knowledge of the patient and the family and the whole person and the whole family, and combine it with the specialist capacity in brain health and how the brain health navigation ought to work inside a overall health system. We heard from Megan Eldred about what the UK is doing and her effort, basically sounding very much like systems around the world in the struggle that they're going to have as they move into advanced diagnostics and adjust their health system to identifying people early in the course of the disease to gain access either to risk reduction interventions or therapeutic interventions. And then the exciting new ARPA-H development inside the United States, which for us in the United States is, because of our experience with DARPA, quite exciting. And at the same time, her global remit, which is powerful because she can partner with us in identifying with you all the problems that we have in changing the systems of health rather than the healthcare system. So I think that was pretty exciting. And then, of course, Tarun and Phyllis both who have been leaders in this space for a long time. And we appreciate their comments at the end about connecting all these dots and strengthening the system. But this is no easy feat. As I said at the beginning, dementia is growing in prevalence and an impact and suffering for families around the world. And as we'll see, with 150 million families by mid-century and families of 3 or 4 or 5 people, we're going to be approaching 1 billion people touched by this disease by mid-century. And the cost to society at $1 trillion a year now, doubling every 10 years. So just in this coming decade, 2020 to 2030, we'll be spending $15 trillion. So it's a pandemic by any measure. And the innovation is happening on the therapeutic side and on the diagnostic side and on the health system side, broadly speaking. And so putting it all together is a no easy task, but our grant recipients showed us the way with local innovations from which we can all learn. So thank you all for attending today. It was a good day, an informative day, and I hope you all have a healthy day. Take care.